In a book put out by Williams and Wilkins Publishers on pancreatic diseases, there's an interesting place in here called Endoscopic Retrograde Cholangiopancreatography that is by KOGORO, KASAHARA, and HIDEO NAGAI. Soon after the first report by McCune in 1968, I published a large series of endoscopic retrograde cholangiopancreatography ERCP studies with a high success rate using a lateral viewing fiber duodenoscope specifically designed for cannulating the duodenal papilla. With its rapid widespread application throughout the world, ERCP became one of the most important diagnostic modalities for pancreatic and biliary diseases. Shortly thereafter, an endoscopic cannulation technique for ERCP brought about the development of endoscopic sphincterotomy 4 and 5, bowel-nasal drainage, and bowel-duodenal endoprosthesis. This chapter describes the overall usefulness and limitations of ECRP, not the endoscopic techniques, but in just the ECRP, in managing patients with pancreatic disorders and pancreas-related diseases. The complications of that are, even in experienced hands, complications occur in 0.6 to 3.1% of examinations with a mortality rate of 0.13 to 0.19%. Pancreatitis and sepsis are the two main complications. Injections of contrast may cause a transient rise in serum amylase and lipase in about 60% of patients after pancreatography. Injection of contrast may cause a transient rise in serum amylase and lipase in about 60% of patients after pancreatography, particularly in cases of acinar specification, and may result in a pyelogram in some instances. These sequelae are asymptomatic in most instances. ERCP, however, may rarely cause acute pancreatitis, which is usually self-limited and only occasionally requires medical treatment. Post-ERCP pancreatitis may be prevented to an extent by careful limitation of contrast volume and avoidance of acinar opacification. Post-ERCP sepsis occurs almost exclusively in patients with poor drainage of the pancreatic and biliary systems. As a result of the bacterial contamination introduced by the procedure, pancreatic sepsis occurs in 0.3 to 1.7% with a mortality rate of up to 0.06% in patients with recurrent pancreatitis. Malignant stenosis and pseudocyst can also occur, resulting from dissemination of bacteria already present in the biliary tract. Septic cholangitis occurs in 0.3 to 0.8% with a mortality rate of 0.05 to 0.1%. When ductal stricture is suspected, the volume of contrast injected should be kept to the minimum needed to confirm the presence of the stricture, but not necessarily depict the lesion itself. Prophylactic antibiotics should be either used perineally or added to the contrast material. However, the most effective prevention and treatment of sepsis is a prompt surgical, endoscopic, or transcutaneous decompression when ductal strictures are found. Other complications of ERCP are either of less importance or uncommon, including instrumental injury, perforation of the biliary tree, extraluminal injection of the contrast medium, drug reaction, and aspiration pneumonia. The normal pancreatogram, common channel. The common bile duct and the main pancreatic duct usually coalesce to form a common channel as they traverse the duodenal wall. In most cases, the common channel is visualized in ERCP as a small caliber duct usually 1 to 15 millimeters long, with a slight undulation of bilious mucosal pattern. Ampullary dilation of this portion is seen in relatively few cases, despite the prevailing terminology of ampulla. The sphincter of Oddi encircles the common channel as well as the terminal ends of the bile and pancreatic ducts, forming a narrow segment of each duct. These narrow segments may sometimes appear undistinguishable from true stenosis with neoplasm or inflammation on ERCP. Fluoroscopic observation, however, can well differentiate it from a pathological stenosis by demonstrating periodic contraction of each sphincter of the bile and pancreatic ducts. The exception is a non-invasive tumor, such as adenoma of the papilla, with which the sphincters may occasionally maintain basic contractions. A separate opening of the bile and pancreatic ducts on the papilla is seen in 2 to 18% of individuals. The incidence may differ depending on whether necropsy materials are used or the living papilla is observed endoscopically. Double papilla of Botter have been reported as a rare variant, but in less than 0.2% of cases. The main pancreatic duct, or duct of Beersung, the three-dimensional course of the main pancreatic duct should be understood. The duct bends anteriorly approximately 2 centimeters before its conjunction with the accessory duct, or the Santorini duct, and changes direction to the left. An anterior-posterior projection of this bending is shown on ERCP as either a smooth transition, sharp angulation, or alpha loop formation, depending on the difference in the angle and position of the turning points. The configuration of the main pancreatic duct has been classified on the basis of the pattern of its course through the pancreas, but these do not appear to be of much clinical significance. An unusual course of the duct sometimes reflects compression by an extrapancreatic mass, but may also reflect a normal variation. The length of the main pancreatic duct ranges from 95 to 240 millimeters as measured on ERCP or autopsy radiograms. Of clinical note is the judgment of whether or not contrast medium extends to the caudal end of the pancreatic duct. The main pancreatic duct gradually tapers as it runs from the head to the tail of the pancreas. Average diameters of the main pancreatic duct in the head, body, and tail are 3.1 to 4.8, 2.10 to 3.5, and 0.9 to 2.4 millimeters, respectively, when measured by ERCP. So that's very interesting. The main pancreatic duct usually has a slight narrowing of its caliber, that is, the fusion narrowing, near or at its junction with the accessory duct, the Santorini duct, which sometimes looks like an abrupt pinhole stricture on the films. This pseudo-stricture does not cause dilation of the upstream pancreatic duct, and normal side branches arise from the side. Another rare normal variant of the main pancreatic duct is a bifid duct that bifurcates into two large paralleling ducts in the body of the pancreas. The accessory pancreatic duct, or the duct of Santorini, the accessory pancreatic duct usually joins the main pancreatic duct at the uppermost part of the pancreatic genu. In most cases, it has a smaller caliber than does the main duct in the head region. The accessory pancreatic duct usually opens on the minor papilla into the duodenum. However, the rate of its patency to the duodenal lumen has been reported as 55 to 60%. Ampullary or cystic dilation of the accessory duct at its duodenal end is often observed irrespective of its patency to the duodenal lumen. The accessory duct, however, rarely loses a connection with the main pancreatic duct. Now here are the side branches. Side branches, both the main and accessory ducts have numerous tributaries radiating chiefly at right angles from the stem duct. Some 20 to 30 branches are seen to join the main duct and the body of the pancreas. The head of the pancreas has a rather complicated ramification due to embryologic fusion of the ventral and dorsal and login. The lower part of the head of the pancreas, including the uncinate process, is dominated by descending branches from both the main and accessory ducts. Pancreatographic changes with aging. The pancreas, as other organs, undergoes atrophic changes with increasing age after full development between its 20th and 40th year. Atrophy is more marked in the parenchymal tissues of the gland than in the mesenchymal ones. The ductal system tends to retain its structure. The ductal system tends to retain its structure despite ongoing shrinkage of the surrounding acinar tissues. These alterations may be reflected on the pancreatogram of aged people as various degrees of dilation, meandering, irregularity of the main pancreatic duct, and tributaries. Despite several reports, it has not been determined whether the duct elongates with aging. However, the caliber seems to change with aging as the pancreas undergo parenchymal atrophy. Epithelial changes can also affect the pancreatogram of normal elderly subjects. Both mucous and squamous cell metaplasia, commonly seen in small ducts, is frequently found with increasing age after 50 years of age. He kind of poor English there. Is frequently found with increasing age. It's frequently found after 50 years of age would be sufficient, as shown by an autopsy study. So both mucosal and squamous cell metaplasia, commonly seen in small ducts, is frequently found with increasing age, as shown by both mucous and squamous cell metaplasia, commonly seen in small ducts, is frequently found after 50 years of age, as shown by autopsy study. The duct lined with metaplasic, often hyperplastic epithelium usually shows segmental dilation, mostly as a small round cyst containing mucoid material, as in mucous cell metaplasia, or calcified stones, as in squamous cell metaplasia, within its lumen. Such small cystic or calcified lesions, 2 to 5 millimeters in diameter, as demonstrated in the peripheral ducts of asymptomatic elderly patients, almost invariably represent senile changes of the pancreas. These pancreatographic features should not be regarded as representing mucus-secreting cystic neoplasm or chronic calcifying pancreatitis. However, mucous metaplasic cysts occasionally require differentiation from cystic neoplasms when they are over 3 centimeters in diameter.